Well, I've been tasked with talking about stroke. Stroke is in the interventional management of stroke, which means basically mechanical thrombectomy. And there's been a couple trials that have come out recently that have been very exciting because they have expanded the time window for intervention. And so I'm going to talk about some of the historical aspects to thrombectomy, and then kind of describe the things that have changed in the last 5 years or so, and then kind of hit on the most recent changes and kind of how we think about stroke. If people have questions, you can yell stuff out. This will be informal. I'm also on call right now for neurosurgery and for strokes, and so I don't have any partners available. So if I get a page, I actually have to leave for a period of time. So hopefully that doesn't happen. But if my pager goes off, so you understand. I'm a consultant for Cerebrotech, which is actually a really interesting thing that I'll just describe really briefly. I wasn't going to, but I just thought of this. There's this company that is manufacturing a headpiece that you put on a patient when they that EMS would put on. And basically it sends infrared and different wavelength light through the head. There's a emitter on one side and a detector on the other side, and it compares the impedance of the wave of the light basically traveling through the brain between the two hemispheres. And I'm the core lab reviewer for this big study, but basically it's highly sensitive and specific for detecting large vessel occlusions and for intracranial hemorrhages. And we're sort of in the process of the studies going forward, but it's exciting new technology that can basically let us identify major strokes before people even make it to the hospital. Anyways, it's cool stuff. But so this is kind of what I do on a regular basis. So this is a 78-year-old male who presents with sudden onset left facial weakness and arm weakness. His stroke scale is 10. And this is a CT angiogram. It's a coronal view of the head, so he's staring straight on at the head. But basically, you have to take my word for it, but there is a large vessel occlusion. The superior division of the right middle cerebral artery is cut off right there. And when patients come in with these large vessel occlusions, we do a CT angiogram to look at the blood vessels, to look at the carotids, and to see if anything's missing. But then we also do a CT perfusion. And so this study, what it is, it's basically, think of it as quantifying the amount of contrast in the brain over time when they do the scan. And so what we see is on the right side, well, on the left side, first off, this is time to peak. So it's the amount of time it takes for the contrast to get to that area of the brain. And because the left hemisphere is fine, the time is low, and so it's represented with a darker color. But on the right side, the time for the contrast to get to the area of the brain that is not being perfused, it takes much longer because it's through collateral flow. And so we see this large area of brain at risk. And so this is the brain that could die if we don't do anything. This is the ischemic area of the brain that is currently not functioning well, leading to the symptoms, and is at risk of dying. Then we have another sequence, which is the blood volume, which shows us basically between the two hemispheres that there may be a small core infarct here, but for the most part, all this brain is still potentially alive. And so we look at this and we say, a large area at risk, none of it's dead, therefore if we reperfuse it, we can potentially save all of this brain that's at risk. So we take him to the IR suite emergently, and this is a angiogram with a catheter in the right internal carotid artery. We inject dye, and we see the blood vessels. The inferior division fills normally. You can see the branches over there, but that superior division is cut off. And we put a big catheter up there, and then we suck out the clot, and now, literally 2 minutes later, all that blood supply has been restored to the area of the brain. And so this is an example of a guy who went home totally normal. So, and this is not like some miracle, oh, hey, look, this is the one patient I've had that's had a good outcome. This is like sort of the norm a lot of times for these types of occlusions. And sometimes you pull out a big goober like this. This is not from that patient. It's just a great picture. This is from one of my patients, though. But you can see how these aspiration catheters we have are fairly sizable. And you can grab the thing and just pull out this huge clot. So that's cool. This is another patient, 7-year-old male, who came to us. He was at a different hospital. He presented with leg weakness, which then rapidly progressed to obtundation. He was given IV TPA at that time. His CT angiogram, this is from the other hospital, I think, shows this is the vertebral artery, which then becomes the basilar artery. And at the top of the basilar apex, he has this sort of, you can appreciate, it's just hard to see what's going on with the blood vessels there. His stroke scale was 31, so that's pretty darn high. He was flown in by helicopter. He was a 23 when he got here, and he had fixed non-reactive pupils, was missing most of his brainstem reflexes, but was withdrawing, I think, in his leg. And I had the discussion with the neurologist at that time that I think this guy is dead. And they said, well, we don't know. And let's just take him and see what happens. The imaging is kind of the CT angiogram. You can't use perfusion. There's really no way to know. You just have to basically go by their exam, and they're either brain dead or they're not. And he was pretty close to being brain dead, but he was doing something. So here's, this is a straight-on view of his head. We're seeing the vertebral artery on the left side. The vertebral artery actually fills retrograde on the right side, but regardless, the basilar artery just stops. So same thing, you put a catheter up, open it up. Afterwards, the top of the basilar is now open. And this guy went home with a stroke scale of 3. And at 1 year, I saw him in my clinic, and he had like a third nerve on the right side that was, like he had a little bit of double vision still, but otherwise was totally normal. So, so those are two sort of exciting cases, but I don't want to go through this. Stroke's a big deal. How we're managing stroke up until recently was we were giving TPA. That was sort of the standard of care, and it's based on some actually really soft data. The NINDS trial, the stuff from the 1990s, if you actually go back and read it, it's actually really soft, meaning that the benefit that was present was pretty minimal, but there was benefit to giving TPA. And so that sort of set the paradigm of you give this clot busting medication if people come in with a stroke and they don't have a hemorrhage on their scan. Obviously a lot has happened since that time, but until recently this was really the only treatment that we had, and it's the only treatment that we have with class 1 evidence. So we had been doing thrombectomies for a prolonged period of time, but really without any data supporting it. But obviously the problem with TPA is that very few people that are candidates for it actually get it, and that's for a variety of reasons. People either wake up and we don't know when the onset was, or they blow it off and then present too late, or they have like one of the 3,000 contraindications to getting it. But so most people don't get it. And the other thing is, I think it costs like $10,000 to give the dose of it. And just as an aside, I don't think I talked about this anywhere else. There's been studies, there's a lot of people now talking about whether we should even be giving it, especially if you're taking somebody right for a thrombectomy, whether there's any benefit to doing it. Because of the cost, but also because the thrombectomy is so effective. There's been studies that have suggested that if a patient goes to a stroke hospital that is not capable of doing a thrombectomy, and a patient is found to have a large vessel occlusion, meaning that their MCA or their internal carotid artery is blocked, if they take the time to evaluate that patient, actually give them TPA, and then drip and ship them to the hospital to get a thrombectomy, the amount of time it adds on to do that it doesn't provide any benefit because they're actually potentially just delaying them getting the thrombectomy like an hour on average by doing that. So a lot of people talk about whether we should even be giving TPA in people that are candidates for a thrombectomy, but that's a whole aside. But anyway, so what we know is that for large vessel occlusions, and I'm going to keep using that term, what I mean by that is we're really talking about a M1 middle cerebral artery occlusion, so the big MCA, an M2 occlusion, which is one of the branches off the big trunk, internal carotid artery, which is a big pipe. In those vessels, TPA does not work very well. So these are studies looking at how effective TPA is on its own for these big occlusions. And it's only about 10 to 15% of them will lyse, ICA occlusions will lyse with TPA, and about a third to a half of MCA occlusions. And the longer the clot length, the less effective. If a clot length is 8 millimeters in size, there's a 0% chance that that medication will be effective in breaking it down and causing and allowing for reperfusion. And we know that if you have one of these large vessel occlusions, the natural history is pretty devastating. So this is through trials that were looking at patients with these that patients got randomized into the bad arm, if you will. At that point in time, there was clinical equipoise, so they were saying we didn't know which one was better, but it turns out that one of them is better, one of them is not better. And those unfortunate people that were randomized into the bad arm, about 80% of them were dependent at like 90 days, and 25 to 50% of them die. So basically, if you have one of these, chances are you're going to be in really poor shape in the future. And so the natural history is devastating. TPA is only so effective in lysing these, especially if they're larger vessels. The larger the vessel, the larger the clot, the less likely they are to dissolve. And so obviously it would be great if we had a treatment where we could actually just remove the clot, right? And so that's where thrombectomy comes into play. We know elbows or large vessel occlusions are bad. Removing them is good. Outcomes are better when reperfusion is better. And so we use this TICI score, which is it's basically derived from the TIMI stuff from the MI. But basically it describes how much of the arterial tree downstream of the occlusion is reperfused. Basically, and we're sort of aiming now for a 2B, 2C, which is like near complete, versus a 3, which is complete. And a good result of a thrombectomy now is basically a 3 or a 2C, which I didn't even include on here, but basically we really want nearly all the downstream territory reperfused, and we're getting that about 75, 80, 90% of the time. So this was the thought process before, and I'll hit on this again later, but timing is critical. This is from earlier trials looking at mechanical thrombectomy, and basically for every 30 minutes that passed from the onset, there was a 10% reduction in good outcome. So you can imagine how if somebody comes in and they're 6 hours out, you would say, well, that's 12 30-minute time periods, so that's 120% loss of favorable outcome, right? So, but the thought was that you had this very limited period of time to intervene. And so if you hit 4, 5, 6 hours, there were people that just weren't getting procedures. They were just saying, well, it's too late. The brain's dead. We can't do anything about it. Even with sometimes favorable perfusion imaging where it doesn't look like it's dead, but people would be like, no, we're too far out. So people would have wake-up strokes. You don't know when the stroke started. Well, we're not going to do anything about it. And this sort of was the mantra of treatment for a period of time. Well, lately we developed better technology. We have these retrievable stents that basically they're a stent that you deploy, but it's on a wire, so you just pull it out. And so you deploy it in the clot, it opens up, it pushes the clot to the side of the vessel, and then you pull the thing out. And when you pull it out, it pulls the clot with it. And we have other technology like these big aspiration catheters where you shove these big catheters as far up as they'll go you grab the clot, you engage with it under suction, and then you just pull the thing out. But we're getting really, really good results now as far as reperfusion, restoring flow. We know from studies that our chance of reperfusing it is getting better and better, and we know that the new devices are better than the old ones because we have data showing that. I'm not going to go through this, but they're just better. And so we're getting about 70-80% of the time we're getting either full reperfusion or near complete reperfusion, meaning that we're seeing all the blood vessels downstream refill normally afterwards. So this is an example of one of those retrievable stents. This is a Trevo device, a 69-year-old male with a basilar artery occlusion. We're looking at an AP, so a straight-on view of the head and then a side view of the head. And the right vertebral artery, the basilar artery is just cut off. You can see it just sort of ends right here. And then we put one of these retrievable stents in, and this has radio-opaque markers on it. I don't know if you can see that, but you can see the actual stent deployed in the basilar artery on both views. And then we inject dye while it's open, so this is with the stent in place. And now you can see contrast actually going through the middle of the stent and the clot kind of pushed to the side, and it's actually supplying the downstream territory. And then we pull the clot out with the stent, and then everything's open. It looks great. This patient died, but pictures are great. It's an example of these basilar artery occlusions are very challenging, because really you don't know how they're going to do, and you're forced to just intervene and hope for the best. And in this case, we made the pictures look really good, but the brainstem strokes were devastating, which you kind of don't know. And then frequently you pull out something like this. So this is the stent retriever on the wire, and then here's a piece of junk stuck to it. Okay, so in 2013, there were 3 randomized trials that were published in the New England Journal of Medicine, which is sort of like, the top journal in modern medicine. And all of them showed no benefit to thrombectomy. This is back in 2013. Excuse me. And that was very disappointing, but all the trials were designed in a manner where they were destined to fail. And so the community, meaning the physicians that do what I do, recognized all these limitations in these trials and made changes, and then did better trials that selected the right patients and used the right treatments, and that was sort of aligned with modern medicine. And all like 5 of these came out within about 6 months of each other in 2015. And all of these were overwhelmingly positive, supporting thrombectomy. And I don't really want to go through these in too much detail, but there's been about 7 of them now, well, plus the 2 more, so we're up to like 9 now, all overwhelmingly positive. But these trials were designed to, they're asking the right question, they were randomizing patients appropriately based on accurate imaging, and they were being done with modern thrombectomy devices at very large stroke centers that know what they're doing, with stroke neurologists that know what they're doing, with neuro ICU management afterwards, with aggressive rehab afterwards at these very large stroke centers. And so it was basically the right people doing the study, doing the right things on the right patients, and they were overwhelmingly positive. And there's a bunch of specifics about each of these that really is not terribly important, but I'm going to show a number of these pictures, and what we're seeing is we're seeing the outcomes basically between medical management or control versus intervention. And we're looking at the outcomes in terms of modified Rankin, which is sort of the way that we describe, it's become the norm for stroke trials and for a number of neurosurgical trials. But basically, it's a scale from 0 to 6, where 6 is dead and 0 is basically totally normal without any symptoms. And 2 being sort of the cutoff for having disability but functional independence. And so a 0 to 2 is considered a good outcome, and that's become the norm. And so when you look at these, we're talking about 0 to 2 good outcome. If you look at the way all the modified Rankin scales or scores are shown, basically you're comparing those with a 2 or less compared to those with 2 or less in this one. You can see that essentially almost a double rate of good outcome in those undergoing thrombectomy versus medical management. What I want to point out is that the odds in many of these trials are still not great. We're talking about 1/3 versus 1/5. But this is highly statistically significant. And if we look at all of these, if I just go through them, many of these were stopped early because they were so overwhelmingly statistically significant. 53% versus 29. But just keep in mind, we're still talking about only half. That means that even in this treatment that is overwhelmingly beneficial, there's still 47% of people that are dependent. Makes sense? So like even though it's good, it's not like that great, right? Another one, 71% good outcome versus 40% outcomes in this. This was a different trial. It had different inclusion criteria, which is why the outcomes are better, but still highly statistically significant. Swift Prime, another one, same deal, 60% good outcome versus 35. Revastat, another one, 44 versus 28. But all these highly statistically significant. And we know if we summarize this data in a meta-analysis, that it strongly supports doing a thrombectomy. We're looking at where's the odds ratio of, I think it was 2, greater than 2 times better odds of having a good outcome versus not if you get intervention versus control. And then if we look at all the trials going all the way back, even the poor ones, and we compile all that data together and we look at it, there's still it was like a 1.8 odds better outcome with mechanical thrombectomy compared to control. So like there's no question anymore. We know that this is the right thing to do for these people. And so in 2015, after all these trials came out, the American Heart Association, American Stroke Association kind of summarized the results. Now these trials were based predominantly on patients presenting within 6 hours. One of them went up to 8, one of them went to 12, but most of them was within 6 hours of presentation. And basically we're looking at, adults with a stroke scale of 6 or greater that have an MCA or an ICA occlusion, because it's the only people that were randomized in those trials. But it supports doing a thrombectomy. And so if you read number 1, if they're eligible for TPA, they should get it, even if they're going to go for a thrombectomy. So don't withhold it because you're going to do a thrombectomy, just give it. But 2, patients should receive mechanical thrombectomy if they meet all these criteria. And so that was a big change. Now all of a sudden we were going from, we think this works, we're not sure, to all of a sudden we should be doing this on everybody. And the reason that these trials were successful, it had something to do with the devices we were using, but it's not just that. And we published this big editorial with a bunch of all the co-authors from the PIs from all the trials, but basically the gist of it being, it's not just about having an interventional person that can do the procedure with these devices on the shelf. It's actually much more important than that. Getting the outcomes that they were showing in these trials and having that benefit was dependent not just on the procedure, but on appropriate triage, getting patients as quickly as possible to the right place, getting the right angiographic imaging, all that happening rapidly, having the right people look at it, having the interventionists to know what they're doing, intervening rapidly, having the stroke neurologists and the ICU doctors to be able to manage them post-procedurally, and then having the rehab physicians necessary to get people better faster. And so having those outcomes and having the benefit from actually doing the procedure it's not just from a mechanical or procedural standpoint. It's much more than that. It's all these people that are acting together to get these patients into a place where they have a functional recovery. So after these trials came out, all of us started becoming much more aggressive. Basically, we were like, now we finally have this data supporting it, and we're seeing these good outcomes, and we all have these anecdotal stories where we have somebody who's near death and they're 12 hours out, we're intervening and they're normal. And so we surveyed all these people around the country, and basically everybody said we're much more aggressive now, and we're taking people to the IR suite that we wouldn't have before. People that are marginal before, where we said, oh no, they're 6 hours out, let's not do anything, it's too dangerous, we're gonna cause a bleed. People were starting to become more and more aggressive. And if we look at the number of procedures we're doing, the numbers are going up and up. Like they are going out of control up. And so this is another study that we did where we just wanted to see what the burden of our call was on our physicians. This is sort of a selfish thing that we did because we're like, our call sucks. Let's show everybody how much it sucks. And so we went back and looked at over a period of time in 2016, retrospectively over a 3-month period of time at these 10 interventional centers around the country. So you can read all the names there. And we looked at how many thrombectomies we did during that time period and then calculated a rate based on the number of days. And I could go and talk more about this, but basically it ended up being, if you look at during 2016, we were doing about, across all these centers, these big stroke centers, about 1 stroke case every 5 days. And then we decided to repeat the study prospectively, actually having people like me sit there and record the times from all the phone calls we get and how much time we're actually doing the procedure and then talking to the family. And we write all the stuff down, once again, so we could use that to complain about how bad our lives are. And so then we repeated that last year, and the numbers were 1 in 3. The amount of time we were spending, every day we were on call, we were spending about an hour on average dealing with stroke, which keep in mind is like, we have like, I do spine surgery, you know, I have elective patients, I treat aneurysms, I do all this stuff. And this is like an hour a day thrown into your day. It could have been at any time, nighttime, daytime, whatever. But the numbers had gone up. And then Dawn, which I'll talk about in a little bit, and DEFUSE 3, which are these 2 big trials, came out. And so all of us were like, this data is no longer valid because the numbers are really going up and up. And so we repeated the study. We're in the middle of collecting it. I'll just tell you that we did our data for Wake Forest about 2 months ago. And as you can see, in 2017, we had 8 thrombectomies in 30 days. We did 18 thrombectomies in 30 days this year. So just like 2 months ago. And the other centers I've looked at, it's basically going to be about a thrombectomy a day at this point, based on the rate that this is going. And so that is a good thing because obviously we're busy and it's work and all that. But it's a good thing for patients because all these people, it's not like people are having more strokes than they were before. This just means that we've realized that we can help more and more people, and we're doing that and we're more aggressive about doing it. This is a problem for Brian and people like you and other people in the room who actually help us do these cases because this is becoming like untenable, right? You have, each time we go in to manage these patients, I drive in from home, but also we have technologists and nurses and all these people that have to drive in from home to do these cases, and these can go on for hours. And like, you can imagine if you're doing these every single night, you can't expect people to come in and do these procedures in the middle of the night and then go home and then go to work all day the next day and function totally normally. I can't expect to be up all night doing stroke procedures and then have a full day of operating the next day because that's not fair to my patients that I have to operate on the next day. And so it's becoming a big concern because unfortunately, peak hours, 8 to 10 p.m. Yeah, and so that's when we're doing most of these cases. That's when I'm supposed to be at home, you know, being a parent and like a husband, and it's not happening anymore. But anyway, there's the issue of burnout among physicians. There's burnout among the people that are helping us, and it's become this big problem. It's a good thing we're helping people. At the same time, like from a logistical standpoint, it's become very, very difficult. So we have to sort that out. This is not really breaking news anymore, but many of you are probably aware of this. There are 2 trials that have come out in the last year. One is called Dawn, and the other one is called DEFUSE 3. But basically, what they're doing is they're using the old trials that were published in 2015 and expanding them. And basically, their aim was to look at patients that were presenting beyond that 6-hour window. And so these are people that have that their onset of stroke symptoms is either unknown, like they wake up with it, or they're found down and we don't know when that occurred, or it is known, but it's between 6 and 24 hours. So all the way up to 1 day. And they have severe stroke symptoms, so they have a real deficit. And then they have imaging, physiologic imaging that's obtained, meaning CT perfusion mostly, that suggests that there's a significant amount of tissue that's salvageable. And usually it's like less than 1/3 of the MCA territory. Most of these are MCA strokes, but less than 1/3 of the territory is dead. And then they randomize them to medical management versus thrombectomy. And so these patients they sort of fill that gap of what do you do with them when it's been a really long time, or when they wake up and you don't know when the stroke happened. But the imaging appears favorable, meaning that it looks like you can salvage a lot of the tissue. And if you look at the results, I mean, it's overwhelmingly positive, showing that we should be doing thrombectomy on these people. 50% of these people were functionally independent at 90 days after thrombectomy, compared to 13% in the medical arm. And so, and the number needed to treat, this is a statistical calculation that basically tells you how many people you have to treat to prevent whatever illness you're trying to prevent. And so you have to treat 2.8 people to prevent like functional dependence, meaning a bad outcome. And that number is hard to interpret unless you know epidemiologic literature, like what that actually means. So putting that in perspective, if you look at other numbers needed to treat from various other things, like you have to treat 5 patients for H. pylori to actually heal an ulcer. So the number needed to treat is 5. If you're looking at like preventing a death or serious medical condition with Lipitor, you have to treat over 500 people to prevent like 1 death or a serious medical condition. Even like to prevent 1 heart attack or stroke, that number needed to treat is 70 to like 250. You know, so like we're putting people on all these medications with the expectation that we have to treat 1,000 people to prevent 1 person from dying. We have to do basically less than 3 thrombectomies to prevent 1 person from being severely disabled. So this number is like the lowest it gets in at least in neurosurgery, like procedures that we do to prevent whatever bad outcome. This number is like, I can't tell you how astronomically low this is, which is like, it just shows you that like these patients need to get a thrombectomy. DEFUSE 3 was another one which didn't go as far out. It went to 16 hours, but basically the same deal. It's looking at people that they have a stroke, it's a severe stroke, they have a large vessel occlusion, they have salvageable brain. If you intervene, you're looking at 50% good outcome versus 17%. So it's this exact same data basically. overwhelmingly supporting doing a thrombectomy. And there are new guidelines now as of this year following these trials. And basically, if you read number 7, it says, essentially, if they present within 6 to 16 hours and they meet the criteria for the studies, which basically means that they're not 100 years old, they're like probably 85 or less, and they have a large vessel occlusion and they have salvageable brain on the scan, you should basically, it says mechanical thrombectomy is recommended. So we should be doing thrombectomy on these people. And then because of, it was only one study, but 6 to 24, it says mechanical thrombectomy is reasonable. So basically what this means is that if they have, and the caveat here, this is not all strokes. If they have some like small lacunar, small vessel stroke, we don't intervene on those people. But if you have a large vessel occlusion, meaning ICA, MCA, ACA, vertebral artery or basilar artery, even though those people weren't included in the studies, basically, regardless of the time course, up to a day, we should be intervening. And a bunch of my colleagues around the country now are trying to look at 24 hours plus, because there are people out there that are a day out and you intervene and they still get better. And so, why is this happening? Like, what does this mean? And I think the way that we need to think about this is to think about these large vessel strokes as a sort of a spectrum. But the way to think about it is you have a tree branch, and the downstream tissue, all the branches and all the leaves on that, that's being supplied by that occluded branch. When that blood vessel is blocked, all that blood is, or all that brain is starving for blood. Now there's brain that is being supplied through collaterals, which are small channels. And basically, if you think about it as a spectrum from that brain is entirely, like it happens and that brain is all salvageable, to being it's all dead. The point where we should stop intervening is currently unknown, but years ago it was you give TPA and it was within 3 hours and not beyond that, and then they looked at more data, more studies, and they said no, now in select people 4.5 hours is safe to give it. And then we knew that, well, we should be doing thrombectomies, but as long as it's within 6 hours. And then now we know up to a day out there's still benefit. And I think what that tells us is that as long as the brain isn't dead, that brain is potentially still salvageable. At some point, there's a no-go, and probably that's when it's all dead. But we really don't know at what point we should be intervening. And we know even that the perfusion imaging that we use tends to overestimate the amount of brain that's dead. And so I don't know where we're going to go from here, but this is data which is a compilation of all those stroke trials I talked about. The investigators got together and decided to compile all the patients together from these major randomized trials. And then they look at and they look at how patients did based on all these presentation findings. And so we use Aspect Store. I don't know if you guys have heard of that. It's a score that we give. It's based on a non-contrast head CT, but it's a score from essentially 0 to 10. And you look at a CT scan for a patient that has a stroke, and you divide the brain into 10 areas. And then for every area of the brain where there's any evidence of injury, meaning early imaging evidence of some injury to that area, you remove a point. And so if their CT scan is totally normal, they get a 10. If they have early evidence of ischemia in like 2 of the little areas, they get 8. If it's half of the brain in that side shows evidence of injury, they're 5. And if all of it's injured, they get a 0. So it's a quick score. But it's a good marker of like how much of the brain is actually injured. And for the most part, we used to be pretty much, if it was a 6 or better, they were a candidate, whereas if it was a 5 or less, there was too much dead brain. and we wouldn't intervene. But so they threw all these patients together from these studies, and they looked at the patients based on these scores. And regardless of basically any of the imaging findings that are present, regardless of how bad the brain looked or how good or bad the collaterals supplying that downstream territory, other blood vessels trying to make up for it looked, there was still pretty much an overwhelming benefit to thrombectomy over mechanical or over medical management. So even if you look at the aspect score, the people that are like 0 to 2 are the ones that their brain is all dead. And of course, well, if it's all injured, there's no benefit. But patients that are as low as 3, meaning that 7 out of the 10 areas are injured, and there's potentially only 3 that aren't on this imaging study, there's still a benefit to doing a thrombectomy. So even in these people where like most of their brain is dead, by salvaging whatever's left, there's still functional benefit to doing that. And well, the thought is that if you leave brain behind, that brain will provide functional benefit. And the thought process is sort of changing rapidly, and so we're becoming much more aggressive. Now all of a sudden there's patients that are coming in where we look at the CTA and they've got this huge core infarct, and we still will take them, and afterwards we see that the MRI scan, the infarct's not as bad as it looked, and they end up doing well. Granted, they still have deficits, but they're not as bad as they would have been had we just left it. But the problem is we don't know when to stop at this point. We do know that if we intervene on people that are worse off, there's more dead brain, it's more likely that they hemorrhage. So we cause reperfusion hemorrhages. You know, the brain is dead, you restore, you imagine this big pipe is occluded, the brain downstream dies, now you reopen this pipe, and now you have all this blood going into leaky blood vessels, and they're much more likely to bleed. But we've learned that we're very aggressive in actually getting the blood pressure down immediately. So when we restore blood supply, we'll immediately drop their blood pressure to like less than 130 systolic, because their brain's now getting the blood it needs. It doesn't need to be 180 anymore. And that dramatically reduces the risk of a reperfusion hemorrhage. And so we've caused the hemorrhagic transformation rate to go down by doing that. At the same time, we're having much better outcomes. And this is kind of like the best possible data you can have. These are randomized controlled trials. This is a meta-analysis of randomized controlled trials, which is like the best possible evidence. And it's showing we should probably be doing thrombectomies on a lot of people that most of us weren't doing before. So sort of in summary, these patients are heterogeneous, meaning that everybody's different, and everybody's collateral supply is different, and everybody's recovery is different, and it's really hard to generalize for any individual patient. Oftentimes we kind of look at the scans and you have to like really think about this, because you get these people that look like they're really bad off, but you don't know. And it's a tough decision to say no, because basically if you're looking at the scan and you're like, should we intervene? Part of me wants to, part of me does not want to at all, because I think they're not going to do well. If I say no, and that's the final word, that patient is doomed to having this terrible stroke with a 80% chance of functional dependence. Whereas if I say yes, then I'm going in the middle of the night and I'm doing this like sort of dangerous procedure on somebody, and I run the risk of tearing a vessel or causing them to bleed or something like that. But at least I feel like I'm intervening and I'm trying. But it's a hard decision to make, oftentimes. People are never clear-cut. It's always like a 9-year-old person that's in a nursing home. Are you restoring quality of life? I don't know. What if it's a 75-year-old person with dementia? Are we doing the right thing by trying to intervene? We don't know. But with this data, most of us are leaning towards being more aggressive. And so we're treating people that we wouldn't treat before. And it, most of the time, well, so they always get the choice from the standpoint that we have to obtain consent unless they're aphasic, which is half the time. If it's a left MCA, they are unable to say what they want. And if it's a right MCA, if their stroke scale is like, 12 or something like that, oftentimes they're not in a state of mind where they're really making good decisions. Frequently they are competent and they can make decisions, but it's usually family. But a lot of these people are sent in from somewhere else and there's no family around. We try calling, can't get a hold of anybody. And it comes down to me and the stroke neurologist being like, what should we do? We try to give people the option. I think the reality is that most of the time we're trying to intervene because it's just probably the right thing to do. I notice my numbers aren't adding up there. But anyways, perfusion imaging, it tends to overestimate. Yeah, well, I guess they do. But the other thing is that the imaging we're getting, it tends to overestimate. So, but you don't know for a fact whether it is or not. And sometimes these people come from other hospitals and they have a CTA. Do you repeat the imaging? Do you give them another 100 cc's of contrast dye and irradiate them, knowing that I'm potentially going to take them right to the angio suite and then do the whole thing all over again and give them a bunch more dye? And that means they've gotten 3 large doses of contrast. And it's none of these patients are easy. They're always complex. I mean, they tend to be older and sick, and you have to make decisions. But so there's a bunch of trials underway looking at a bunch of other stuff. But I think the key here is that there's benefit to intervening well beyond what we thought there was. And I would make the argument in the next 5 years, we're going to have even more data suggesting we should be doing this on like a lot of people that we never would have touched before. But sort of an exciting time in stroke care. I'd be happy to take any questions you guys have. Yeah. I'm sorry? Yeah. We take them regardless of whether TPA is given or not. And so if they come to the ER and they get a non-contrast head CT and it shows no blood and they meet all the criteria, they start getting TPA. They then get the CT angiogram. We look at the pictures. We wheel them to IR with the TPA running, and we do the procedure. If TPA, regardless. The ER physicians frequently, like, they're worried about catheterizing people, doing arterial lines and things like that after TPA. I mean, we routinely shove these enormous catheters in people through the leg. I mean, putting huge holes in the artery, giving a bunch of blood thinners, and it doesn't matter. That's why you can imagine if they're going to get a thrombectomy, why spend that time like talking to them about whether they had surgery in the last 90 days or whatever? Why even start the drip and give it and spend the $10,000 giving it? Whatever the effect of that TPA is, that huge catheter I put in there to suck out that clot is going to be 1,000,000 times more efficacious anyways. Why delay them in getting to that position where we're in there treating it? So a lot of people are talking about doing a randomized trial now, just comparing thrombectomy alone versus thrombectomy plus TPA, because we feel like it's probably not terribly beneficial. There's a role for it, obviously, in people that are elsewhere and there's nobody capable of doing a thrombectomy because it will potentially break down that clot while they're in transport. And so then it is beneficial. Well, we would have to rule out a hemorrhage first, and that's the hard part. So there's mobile CT. There's mobile stroke units. They're in Houston and in at Cleveland Clinic. There are stroke centers that have developed these mobile stroke units, which basically they are an ambulance that has a CT scanner in the back, and they do CT angiograms in the ambulance. It sounds great. The problem is that it's like very cost ineffective because of the fact that like one ambulance can only do so much, and if that ambulance is on the other side of the city, they have to drive all the way over and pick somebody up, and it's faster just to grab them and take them. But also, like, they have to stop driving while they're doing the CT angiogram. They can't like do it with the, but so they have that technology. It's really expensive, and we're unsure if it's beneficial yet. But people are trying that. But we have to get a CT scan first, because if they have a hemorrhage and you give TPA, they will die, and so you have to rule that out first.
What about cerebrospinal? Does that show whether it's a hemorrhage?
It can, but that's obviously like that's experimental at this point. Yeah, yeah, but that's like that. I mean, we're just doing the initial trials at this point, but stuff like that. I mean, there's people that are developing these obviously there's pre-hospital stroke scales, right? So there's scales that EMS use that are fairly predictive of a large vessel occlusion, because they can do very simple, like 3 tests. And if they're positive, it suggests that there's a cortical problem, which implies large vessel blocked. But there's other people that have developed ultrasound, like these transcranial Doppler things, but it's so user dependent, and somebody has to interpret it. That's why this visor thing that they've developed is pretty cool, because it's an algorithm. You put it on the patient, you hit a button, and then it says yes or no. Meets criteria for a comprehensive stroke center because they have evidence of a large vessel occlusion / hemorrhage. Take them right there right away, versus no, which would be nice, because then we can expedite transport. But that is experimental. Questions? All right, thank you.